the June CCCT monthly meeting. And we want to start just by having a little icebreaker. Please introduce yourself either in the chat or if you would like to come off and talk to the group if it's your first time. Your name, your organization, and I know we didn't give a lot of time for introductions last time. So if you were new last month and did get a chance to introduce, please feel free to also speak up. But for our icebreaker today, I wanted everyone to provide, and there's no right answer, what they think is one of the most important community health priorities through the summer months specifically. Okay, I'm starting to see some answers in the chat. Some of these important public health initiatives that we need to, or priorities through the summer, meals in schools, activities for youth, drowning. And I didn't introduce myself for everyone that might not know me, but my name's Kim Stinchcomb. I'm the manager of the Healthcare Action Coalition. Dr. Carter, do you want to give a quick introduction?
Good morning. Yes, I'm Dr. Ernest Carter. I am the chair of the CCCT, and welcome everybody. I'm looking in the chat and we're getting a lot of good responses. We've got 27 people in the meeting, so we may not have time to go around to hear everybody. But if you do put your name in the chat, and really these community priorities are really important to us as we start to formulate how we best aid care coordination in Prince George's County. So thank you.
Right. Yes. Thanks all please continue to put your information in the chat. And we can go ahead and keep moving forward for today. So to quickly go over our agenda, we are going to do a little bit of reflection. We've had a lot of movement this year so far, so we want to give a chance to kind of look back and take some time to talk about what we've done in these first 6 months of 2024. And then we are going to move forward with some of our objective development. So we've talked about some of our goals and building those into our initiatives, and we've met with partners, but what are our specific objectives and how will we measure our success? Then we'll talk about some of the next steps that are coming up for CCCT. And then finally, we'll open to any community announcements before we adjourn. So as always, we want to remind everyone the CCCT vision and mission. Our vision is that Prince George's County is a place where everyone has access to high quality and effective healthcare services that are well managed, seamless, and tailored to their specific needs. And our mission is empowering healthier lives through efficient care coordination with a strategic systems approach. So to give us a moment to reflect on some of the wins we've had so far this year with CCCT. So we started kind of the end of last year and into this year focusing on strategic planning. We did complete that broad brainstorming activity where we all completed a Jamboard to address our priorities and some of the barriers to access to care that we've been facing in Prince George's County. And then we used that feedback to help develop our vision, mission, and our 2 goals that we have right now. Then we've started exploring some of the available resources within the county, specifically around community resource inventory. So we found that a lot of our community health workers said it would be beneficial to have a single source of truth community resource inventory that they could utilize, so that they're not doing this tedious task of updating lists of resources that are available. So we started by meeting with 211 and getting a presentation on their resource directory. And last month we had a presentation by Find Help on their community inventory and referral system. I think we found that there are a lot of great free tools that we can use through Find Help, and that you can become a registered um, organization and find help for free. And finally, we've had ongoing partner engagement. Again, mentioned our community health worker panel discussion. We had a presentation by community engagement and consultation group services. And on these calls and kind of also behind the scenes, we've been coordinating with the Department of Social Services, Homeless Resource Connections. Thank you to Jay for doing that, advocating for this group. I know we found that through our CHW reflection, that a lot of times it was difficult to make connections with homeless resources and housing support. So we're hoping to be able to address some of those pathways for how we can identify when there's housing insecurity in the healthcare setting or health setting, and make those connections with homeless resources. So giving a second, if there's any additional comments or maybe anything I've missed from anyone's experience so far with CCCT. But I think we've had great progress. So thank you all for continuing to join. Some of our next steps, I mentioned we need to do a little bit more objective and work plan development. We have a lot of really big, great ideas. So we need to just pull together a couple ways to measure the success of those ideas and really map out exactly what the steps are for success for this group. And next month, we actually have a presentation from CRISP to continue kind of our CRI, but also other resources presentation. So they will be giving a presentation on some of the referral tools and also the social determinants of health tools that are available now with CRISP. And we will continue to develop our use case, looking at those referral pathways from healthcare to homeless services. And just to tie the presentation with CRISP back together a little bit with some of the things we've already done, we've heard from Find Help and 211 that there is collaboration and coordination with the resources that are going in through those platforms with CRISP. So it'll be interesting to hear a little bit more about how they're each talking to each other and making sure that those resources are carried over across the board.
Now, one of the things I'd like to add to that is that this is the CRISP presentation is an exquisitely important presentation. And the reason for that's why I would want everybody who is in this space to really attend this, is because the CRISP really should serve as a universal care coordinating referral tool for us. And it should have all of the things that you really need to make those referrals. So we need to hear what they have and critically think about how we might add or however we do it and how you incorporate that into your tool. A lot of times, and I'm running into this with other entities that I'm working with, every clinic, every hospital, every community-based organization has their own way of doing referrals. But then when you try to evaluate it, analyze it, or optimize it, you have to go into so many different systems, and you have no way of really clearly collecting the data needed to understand how to make it better. So using a centralized system that is already connected to all the hospitals and electronic medical records in the state, optimizing that for doing referrals, especially once they start to integrate their social determinant of health tools, is important. And we need to know as a community how to best leverage CRISP. So this is an important meeting. I mean, I just want you to know in terms of how we ultimately get to our promised land. We haven't really talked about the promised land as much, but our use case will point that out as in the next several months as we developed out the use case. It'll make sense to have a referral tool as robust as CRIS can possibly be. And it has the potential of being a very robust tool. Thanks, Kim.
Thank you, Dr. Carter. All right, so moving into our work for today, we talked about that we need to make this objective development. So a couple of reminders and considerations. I'm sure you all are familiar with some of the rules around developing our objectives. So we really want to think of how can we quantify the success of CCCT in relation to our goals? How can we go back and put in a plan the success and everything that we've achieved in a measurable way? So as always, our objectives should be SMARTY. They should be specific, measurable, obtainable, realistic, time-bound, inclusive, and equitable. And a couple of questions that we want to consider as we throw out ideas for these objectives is what measures will be most helpful for our purposes? How do we define each measure? How will we get the data? Can we get the data? What's our current performance? So what is the baseline that we're trying to move the bar? And always to be wary of unintended consequences. So here, and I'm stealing this example from a recent training from IPHI, but they talked about the bike lane example. So a neighborhood wants to add a bike lane to increase the walkability and increase new ways for transportation. But they know that there could be unintended consequences of developing that bike lane, whether it's loss of parking spaces, maybe it's not utilized appropriately, but there could be unintended community consequences. So we want to be aware of what those could be as we develop objectives. So continue to keep that in mind. So I'm going to go ahead and dive right into our first goal. And so when you're looking at this, we've right now developed some draft objectives to kind of get everyone's mind in the area, the realm that we're looking at. So our first goal is to identify and improve connectivity with existing community health resources. So this is kind of where our community resource inventory is coming into play. And some of these objectives that we've drafted, we are not actually sure if we have the data to support them right now. We would need to have some discussions with the community resource inventory that we select, whether that be find help or if there's a way we can capture this through CRISP or 211. But just throwing things out there for consideration, we thought that this could be a useful way for us to measure the success of what we've been working towards. So let me go back. So I want to hear from everyone else if there are other metrics that you feel like could be appropriate for us to measure the success of this goal. So how do we improve connectivity with existing community health resources?
Hey, well, my name is Michelle. I'm from Institute for Public Health Innovation. And I think this is great. I guess the only other feedback that comes to mind is in addition to the increase the number of registered community organizations, do you want to include a number of like outreach opportunities to the community organizations as another metric? Or, social media campaigns, or, just the methods in which you want to engage with them, or maybe that would be a different goal.
Can you maybe elaborate on that a little bit more? So are you saying um, just ways that we're engaging community organizations?
Oh yeah, I was just thinking as another way to measure success is not
Mhm.
only to increase the number. I mean, ultimately you do want to increase the number, but also if you wanted to increase add like an objective 1.2 or something, and to say, you know, how you were going to do that. Would it be through like social media campaigns, outreach at health fairs, and also utilizing existing networks such as Find Help, CRISP, whoever else is out there?
Okay, I get what you're saying. So I think we would start to focus more on the specific how we address it when we start building out the strategies. Um, so if it's promotion of the community resource inventory and bringing people on or doing that kind of outreach. But I think yes, I like that feedback, and I think that's definitely on the right track of promotional opportunities. And yep, so I'm going to write that down on the side as kind of something for us to remember when we dive more
Yeah, I
into
guess
this.
just to elaborate, I'm thinking of those organizations who are operational, but they may be a very small operation, but very functional in that neighborhood that we may not find through a website, because they may not, not everyone has a website. Some people use Facebook. So I'm just trying to capture everyone. I'm just trying to think how we could capture everyone who's not, that we can't just find online, for instance. So, and also like word of mouth. That could be another way when you get to the house. I'll just pause until we get there, as I know you're just trying to evaluate if this goal is good. So,
Thanks, Michelle.
Kim, I just had another question, and maybe on another objective that, because I didn't, is like, are we going to, there may be gaps in community resources that are needed, or is that going to be collected somewhere? So not only connecting with existing, but identifying a gap that may need, that may be needed.
Mm-hmm. And I guess I think that's definitely an important piece here. I wonder how can we measure, how can we determine if there's a gap? Would it
Well,
be
I'll say for maybe something like, we know that there can be, um, if we're transporting people from their communities to another area because of lack of resource. So building, capacity within, like if we're finding that we're doing a lot of that, or it doesn't have a program with that specific capacity that we keep either bringing people in or taking people out. I don't know. I mean, something like that is what I'm trying to conceptualize here.
mm-hmm, mm-hmm.
And I mean, I know this may be, I mean, I don't know, let's say if it were, I'm trying to think of an area, because, there's, Prince George's County is so vast, from one end to the other. Some places lack resources and others have an abundance. So just, I think they were doing something that's going to come to mind is, like a food pantry. Let's say something like that. Let's say there may be a small pocket of a community that they don't have a food pantry that's accessible.
So are you asking uh, about their connectivity, or are you saying a gap in the connectivity, or a gap in the fact that it's just a lack of resource?
I think it's identifying the lack of resource. Those would be the kind of things too, because it's identifying improved connectivity with existing, but are we going to look at maybe if there is a gap in a resource in a particular area?
Yeah, and I think you're right about, I think we should look at the gap in resources. That would be a different goal, but
Okay,
it'd be a different goal because we would want to gap in resources would then have to have its own objectives, because that's a huge area, and I think we've got to consider that as a goal. So I agree with you that because we do have, one of the problems we have in Prince George's County is that there is a lack of resources. It's not the abundance that you can see in certain jurisdictions, like here like in Baltimore. There's not a lack of resources. Well, it is, but there is a lack of connectivity. So we got to define, we do have to look at the difference. And so what we're trying to do with this goal is to improve the connectivity of the existing resources that we already have and see if we can optimize that. And then we also, in parallel, though, we should have a goal where we try to increase the number of resources, period. And that's a whole different goal, but we do need to define that gap and then figure out how we do that. So I think that's a good point to bring up. And as we go forward, we're going to have goals that will pop up, like, and we're going to need to pursue those. So I'm just going to say to Kim, we put that in the ledger. It's a harder one to do, though, because to increase the number of community resources, that requires county council, state, real funding to help people. We have a lot of struggling community resources, just like that was previously mentioned, that can't even afford a website. They're small, they're mighty, but they're small, but we don't even know who they don't know who they are. Now, if they are there, if we could increase their connectivity, that would increase their presence and their usefulness. But to get a new one off the ground or to get new food pantries and that sort of thing requires a different level of intervention and funding. So we really do have to think about that also.
Yeah, I think that kind of works when we think of kind of our process over time. And I do think we've addressed that before as a strategy of trying to identify those gaps once we've identified our community resource inventory. And I think our thought was that we get a really good idea of what resources we currently have and make sure that they are present in the community resource inventory so that we get that good snapshot of what do we currently have. And then to speak a little bit more to Michelle's point about places that don't have a website, I think making sure that we're connecting with those resources and getting them on the community resource inventory, because just because they don't have a website, they can still be in the community resource inventory with a phone number or an email, any other way to contact, whatever the preferred way to reach them is. And of course they have the option not to be a part of that, but if they want to increase the way that people can reach them, that is still a method. So if people are calling 211 and asking for a resource, they could connect them, or calling a community health worker and asking for a resource, there'd be a way to connect them. But I think that is an important point to figure out how we can engage those services that might not be seeing this movement online.
And I agree with that. I think Michelle's point was really good. I mean, it is a task under one of our objectives, and that we clearly have to have a way of, first of all, letting people know that we have a community resource inventory that they can be part of, that they can utilize. They also need to know that we're going to have ways for them to make smooth referrals. Once we get together with Chris, but we have to have some kind of, we got to market to them. I mean, that's all in. I'm sure under a lot of our objectives, there's going to be a marketing component, a way to make sure they know that this is what CCCT is working to get them connected and get them validated as a resource. So it's a good point. It's a really good point. One question I have for you all, we didn't say by what date on here, we don't have what day and how many years and all that, but it would be interesting to get your sense of what that should be. Okay, so I'm going to tell you. Yeah, when we get to 2025, we need to have clear results of increasing our number of folks connected. This should be a minimum, well, I won't say minimum, but there should be, I would think, at least by 6 months. I mean, by the time of next year, we should have increased over baseline the number of registered community organizations in Prince George's County who are identified in our and that increase has to be quantitative. We need a 20% increase or a 10% increase. We have to say what that increase is. And with all of our objectives, they all have to be quantified, in terms of when we think we can get it done, 6 months, or if we think in years, and by what percentage do we think we can get done? Say, I believe in 6 months we can get a 20% increase. I mean, I'm not unrealistic. If you say we're gonna get 80% increase, that's not gonna happen. But I just want to get your sense of it. But my sense is that after this meeting, and once we establish the task under these objectives, and that has to be in very short order, we have to then launch how we're going to go about getting these increases. Because we're pretty much at the point where we're going to identify the resource, find help or whatever it is. We're going to say this is our resource. These are what we're going to be looking at, and we're working real hard to see how we can get data out of that so we can understand what our baseline is. But then we've got to have these tasks under there, just like Michelle said. How are we going to increase these number of people on there? We got to advertise. We got to tell them. We have to have webinars. We have to have whatever those tasks are. We got to do those things, and we got to do that within this 6-month period, so that we can evaluate this in January and say, we think we can increase it by 20%. If we could increase it by 25% or 30%, we've really done our job. If it goes up by 2%, we're going to I have to call all of you all to task. That's all. That's the way it is. Okay, thank you.
Thanks, Dr. Carter. Oh, go ahead, Michelle.
I was just going to say, when we're talking about increasing the referrals, I agree. And hopefully our partners with Find Help, Unite Us, all those that are doing that sort of collection, hopefully they can, share data. So I don't know if MOUs with them or if just, their agreement is enough, but however we can make sure that they share that to get you in a good place to get started. The other piece that's hard with this, which is why a lot of people don't do it, is because you can add resources and then you need a mechanism to verify resources that are no longer in existence. So in addition to adding, my feedback is also for maybe another piece to it is just along with the date also include validated or verified, which because we're talking about adding, and some of it you'll be subtracting. So you'll get like a net of resources, which is just how it is in my experience by such and such date. And it always fluctuates. So you just kind of need a dedicated person or mechanism to just check that within, maybe once a year or what have you, because it is very time intensive, as I've had to do this myself for another region. And it took a considerable amount of time. And one of our staff persons, she actually does this for the food resources as part of the Food Equity Council. So she's been doing that with Find Help.
I see.
I may be asking something that's already been asked, but who is it that's going to maintain this directory?
So the idea would be, if we're working with one of these partners, so I'm not sure if you were available for the Find Help presentation, but Find Help manages their directory internally, but they also call on community partners to validate and update their resources. So they have all of the information in, they have a couple of different ways of getting the information, but then they have a way for individuals to take ownership over their organization. So they can go in and say, yes, everything is accurate. These are some updates we need to make. They also call on the public to make corrections or updates. So if someone is experiencing trouble getting in touch with a resource or a CHW that's referring people, and they say, we've been trying to reach them, this doesn't seem to be a valid source. So it's kind of a checks and balances type of system where they have their own internal process and people checking in on resources and making sure that they've been reviewed at a certain frequency, but that they also call on the organizations and the public to review them. And the idea is it takes the responsibility of managing something like this out of individual organizations' hands.
Thank you. I appreciate it. I'm sorry I did miss that. So as the local behavioral health authority, we do have a vendor list, if you will, resource list of all of our licensed providers. And because we are an administrative monitoring body, we kind of maintain the list of our behavioral health providers. So I'm just wondering, how do I share that with Find Help so that they can include that as part of their directory, if that's what we're calling it? Is one question. And the second thing would be, I guess I would probably want to talk to them about how we would communicate if they were coming across information that was outdated or not reaching vendors, that kind of thing, how they would then report that to my office so that we could respond to that.
That I am very sure that they would love that information. We can make a connection maybe offline and
Okay,
with
that'd be great.
CG around what the process would be, if it has to be, if there's a way to do kind of a bulk drop of these resources that you have instead
Okay.
of reporting them as individual resources. The alternate would be that we can engage behavioral health partners and ask them to go in and add their organization if it's not already there, and then they would have the opportunity to validate it, and that would give them a lot more information around the referrals that are coming through.
That's true. That you make a good point. Okay. Well, we'll talk about it offline then. Thanks.
No, that's a great idea though.
Hi, this is Twanisha. Kim and Eugenia. We can speak as well because we're meeting with Find Help now. We actually had a meeting a few weeks ago, and we have a follow-up meeting, I think, within the next week or two. So,
Perfect.
Excellent. So it sounds like, based on some of the feedback, that these draft objectives might be going in the right direction. We'll have to coordinate once we understand if we have access to the baseline numbers. We can maybe talk and discuss what kind of increase we would like to see and what's realistic within what timeline. So I think we understand what our next steps are, talking to the partners. And Michelle, I'm looking at your question. Have we done any data collection among community organizations, healthcare facilities, and have a list of all the systems they use to send referrals? We've done a little bit less than a broad outreach. We did our community health worker panel, but we haven't gone out and collected data across the board from community-based organizations.
Okay. I don't want to take up too much of your time, this is an issue that I'm working on in another area, like literally the same issue in Prince William County, Virginia, but along with other community partners and government agencies as well. And they've even put funding towards it to create that system, to have a coordinated system. And it's a great idea. It's absolutely needed. There's just so many logistical challenges, particularly around sustainability, that which you all are, of course, aware. The other issue that we've come across is that they put together a system, but then when it was implemented, the folks at different organizations and agencies said they didn't do it. And when we found out why, it's because, well, they're already doing it for their internal grant reporting, and they didn't want to do yet another system to update. So that integration piece and getting everyone on board to streamline it, I think is critical for this, for the ultimate success of the project. And that's why I asked around the different community organizations just to have a list, because they may have, many times people have their own data systems that their grants managers have in place as well. And I just didn't want things like that to create a barrier down the line. But again,
No, we've
really,
had a lot of experience with that in Prince George's County. As a matter of fact, with Tanisha's on the line with Prevention Link, we started almost 10 years ago looking at how to best optimize sort of like care coordination and all of those things you mentioned, all those barriers we've run into. And it's slowly but surely we've been working with our provider community and hospital systems, et cetera. But it's a long process to get to integration. And one of the pillars of that, though, is that you need to have, in which we do have here in Maryland, we have a health information exchange that is getting even more robust, and it's now starting to focus on population health management tools, like for instance, the referrals, and those are population health management tools. And the good news is with Chris is that Chris, if it works like it should work, and it took a long time for us just to get with on the electronic medical record side, but if this is not a short-term solution. This is a long-term solution. It's a lot of work to be done. So no, but we understand, we actually understand the struggle. Now, one of the things that is important though with this group, and we'll talk about this moving forward, is that we're going to need to be funded to do a lot of the work. Like for instance, when we say collect data about X, Y, or Z, not unless Kim quits her job and gets out there. We don't have enough infrastructure in our CCCT to do a lot of what we need to do. Now, having said that, we're going to get it, and we're going to get funded for it. But we're starting with we're going to start here with understanding how, with some of these goals actually are things that we're going to be able to say we looked at, we addressed, and here's the data, so that we can get funding to get to that next level. To get to true integration is a huge cost, to be honest to God. And we know that that's not something that we're going to do tomorrow, but we're going to work toward it. And this is the group to do it. And so hopefully with our initial goals, if we can get data and do a real evaluation, do the real analysis on that data, then that gives us the platform to get funding. Because you can get funding and say, oh, these are problems, and people don't give you any money. If you say these are problems and look at what we've looked at, and this is what we found, and this is what we have attempted to do, then you have a greater chance of moving to the next step. For communities like ours and smaller or larger communities, it's really difficult to get this particular work done, but we're going to get it done. We believe that this group will get us to that next level. I hope that helps.
yes, no, thank you so much.
Okay. I think it might be a good time for us to switch to our other goal, which was promote data sharing between partners. So on this end, our draft objectives are focused more around the collection of data about social determinants of health screening. So the first draft goal is by state, increase the percentage of patients who are screened for social determinants of health by healthcare partners. And of course, we would want to define that a little bit more specifically, but whether it be primary care physicians, community health workers, or hospitals. We know that it is now a requirement for hospitals to do social determinants of health screening for inpatient stays. But of course, that's not required yet for emergency departments. And then we know there's other opportunities to identify any housing insecurity, food insecurity, maybe earlier on before they're reaching the hospital. So for this piece, we'll need to get a little bit more information from CRISP next week and continue conversations around data availability around social determinants of health screening. So to really understand, if we know a baseline of how many people are getting touched by the system and entered into CRISP, and then what is that numerator of people who are actually getting screened? And I think I saw Gina's hand up.
Yes, I'm sorry.
Don't be.
Is there an accepted screening tool or assessment tool for these social determinants? A uniform tool that most folks use?
And
It's all over the map.
Okay, all right,
Is there a
that's the
uniform
answer.
tool?
Okay, I got
You
it.
know,
All
there
right.
are, early on, CMS developed a tool for screening for social determinants, and this has been an evolving process. One of the things we did, and again, I know some of them, not the folks on the phone who are in the health department, when we were looking at seeing if we could consolidate some of these assessment tools into one universal tool. But we didn't succeed at that. I mean, because it takes first you're not going to get everybody to adopt a universal tool. So the next thought was, well, you use your tool, but if we could extract your data into the universal tool, then we could evaluate how the screenings are being done. So that's a work in progress. Now, one of the reasons we're looking at CRIS is because that's one source, and we can evaluate that source. And so we're going to move on that. A nice project would be to get some funding and look to see if we could go back and see if we could integrate all of those assessment tools so that we would have one common standardized way of looking at social determinants across all care coordination entities. We did not achieve that, but we're still working toward it. So that's why this because ultimately you want to have data sharing among your partners, especially if somebody goes to the food pantry, but it turns out that, they may just found out that they just became homeless. So they're going to need a referral, and you need to be able to share. You need to have people at all points doing these sort of standardized social determinant of health assessments. Because you can see how that could work. I mean, then we're one collective. Everybody, no matter, there's no wrong door. You can, whether you walk into the emergency room or whether you walk, you come into a food pantry or wherever you come, wherever you show up, that assessment happens. You get activated, a referral occurs, and all of a sudden you're getting what you need. That's you're sort of like the holy grail of doing this kind of work. So we're starting with seeing how, with the screening tools that CRIS has, but I'm going to tell you, we're going to expand this objective. I mean, we're going to start with CRIS, but this objective is a huge objective for us to be able to get to the point where we can evaluate our entire system's response with respect to social determinant of health screening, and ultimately get to the point where we have universal way of capturing that data and making no wrong door for our people in need.
Thank you.
And then for the second objective, draft objective, I would really be calling on DSS, to know what kind of data would be available as a baseline for those number of referrals coming from healthcare partners into homeless services.
Thanks, Kim. I was going to jump in even if you hadn't called on me. Yeah, my main question here is just to make sure we know when we use the term referrals, are we talking about successful referrals into homeless services, or are we just talking about the connection to homeless services? Because from our perspective, and I've mentioned here before that we're in the process of getting better data analysis for our unserved population, and not just in homeless services, but across a lot of different domains. So if somebody contacts our homeless hotline, as we've talked about a couple of times here, and in that conversation, it turns out they are also experiencing food insecurity, and they are also in need of getting reconnected to their Medicaid because they need hearing aids, and it turns out they also need dental care, right? Like, we're trying to make sure that we're capturing all of those needs, whether they can be met by our system or whether we are simply making sure that we know that those are unmet needs across the community. So I would say, for us, it would be a great benefit to increase the number of contacts from healthcare providers to homeless services through the hotline. If we could do that through CRISP and, build the infrastructure for that to happen through CRISP and find help, that would be great also. But even just those contacts through the hotline would be helpful, because we have our own internal tracking mechanisms to say we've received, in the last 30 days, we've received 123 calls for emergency shelter. 72 of those were determined to be somebody who is literally unsheltered at this moment, and we were able to place 20 of them into emergency shelter. You know what I mean? Like, we have our own internal processes for tracking all of those. If as a part of the CCCT process, we knew that we were increasing the number of those contacts from healthcare providers to the hotline, even if they don't result in a successful referral to shelter. And I think that's the real key. That's the part that we have to, like, our street outreach team spends a lot of time and energy working with folks that are literally sleeping outdoors and reminding them that the best way to get into emergency shelter is to be persistent and to call the homeless hotline every morning when they've told you to call. Call the hotline every morning at 8:30 or at 8 o'clock or whatever you were instructed to do to check in. That's how people get connected. And it's difficult because people get discouraged when they call a couple of times and they don't get into emergency shelter, and they just say, forget it, I'm not going to keep calling, or forget it, I'm going to just go to DC and get into shelter there because I can just walk up to a shelter and get a bed. So the extent to which we can increase that persistence, both among the residents of Prince George's County, but also the service providers in Prince George's County, that will help us make a better case about the unmet needs for emergency shelter, which has a direct relationship to how much funding we can ask for.
Yes. Yeah. Agreed. I agree with you 100% on that, Jay. So we definitely should look at that. I mean, I think we should look at both. I mean, it'd be interesting to see, because it's going to tell us some information, the ones that are not successful, but you increase the number of times they try, call a hotline or made referral through Chris or whatever, and then the number of successes, because that's going to then tell people, as that number goes up, but your success rate stays at the same 20% success rate, that's going to give you, that's a strong public health advocacy for policy, policy change at the council level and everywhere else. So I'm very much into, understand what you're saying, and I think that's what we're going to address in this objective. Then, isn't that right, Kim?
Yes, that was definitely, and I think that aligns that we can change the language to contact if it makes a little bit, if it's a little bit more clear. And that aligns with the idea of data sharing. So we want our healthcare partners to share information around when they're identifying that there's a need, and how can they do that. So we would be in charge of development and implementation of that path. Great. Okay. Well, that sounds great then. I think one of the things that is in the back of our mind as well is if we need to do additional data collection, if there's not a clear answer from any one entity around how to get this information. So we've considered building some kind of outreach for our community partners to understand what electronic health record are people using, are healthcare providers using, or health workers, community health workers using, what is their baseline referral processes. So that comes back around to what Michelle mentioned before. And then what are our partners' social determinants of health screening practices? So to start building some kind of tool to measure that, we would need to get a better understanding of what partners we need to engage or what partners we need to prioritize to answer these questions. And then what is the best way to reach those partners? I will give everyone a minute to ponder those questions. If anything comes to mind, please feel free to jump in. And I will add that we know engaging, especially, our primary care providers, we want to be very specific and intentional with any outreach. And we want it to be brief, but also answer any questions we have at one time. So it's like we want everything, but how do we make that happen? I know, so one of the groups that we do have regular contact with in the healthcare field is our federally qualified health centers. So we do have ways to engage them. Jay's actually going to be attending a meeting with them in a couple of weeks. And Jay, go ahead.
Yeah, I just to the question of how we achieve the completely contradictory goals of having brief assessments that get all of the information that we want. That's a thing that we wrestle with in homeless services, and the model that we are working on implementing, and the sort of standard model across the industry is to use a progressive engagement model. So making sure that there is essentially one assessment where everything is integrated and all of the partners have access to the same assessment, but it's in parts. So you only need to ask the first 5 questions when you're having your initial conversation with somebody. And that gets the most important information that you need at the very beginning. And then as they move, we don't need to know the social security numbers of all of the family members in order to get somebody into emergency shelter, right? Like that's not a question that we need answered at that point in the process. We need sort of like the names and their current location and what are their shelter needs. And then we can get them into emergency shelter. Very shortly after that, in order to start doing any housing conversations, we're going to need the social security numbers of all of the members of the household. But knowing, essentially having an assessment model where there's essentially one assessment in parts, and people only access the parts of the assessment that they need to in that moment, and constantly asking ourselves as service providers, are we asking more than we need to in this moment? Like, could we put this question off until later? Is this a question that really could be handled by somebody further down the food chain? So that is a strategy that we use to address that, that we are getting the necessary information that we need at each stage in the process, but we're only getting the necessary information we need at each stage in the process. It's actually not unlike the, is it a progressive intercept model, or there's a model that is used in Department of Corrections that's very similar, where it's basically just like you're engaging with people at the point where they need that level of engagement, and you're not asking for more, but you are probably going to ask for more later in the process.
That makes sense, and that's helpful.
Yeah, it is helpful though to make sure that it is part of an integrated assessment sort of schema. Because if you're just saying, oh, well, shelter providers only need to ask for shelter provider information and housing providers only need to ask for housing provider information, there's a lot of overlap there. And if it's not part of one integrated assessment scheme, then you're going to have people answering the same questions sometimes 4 or 5 times. And especially if those questions are related to trauma, you're re-traumatizing people every time you ask for that information. So it is in addition to it being progressive in the sense that it's asking for a little bit as they move through the process, it's also really helpful for it to make sure that it's integrated.
Yes, this is Mike. I totally agree with what you're saying, because we experienced this also with the assessment we were doing with the CHW, the community health workers. We had a very, broad and comprehensive questions, to ask for residents when we do the screening. But it turned out that we were having less people, because people didn't want to respond to all these questions, like 25 or 30 questions. So we ended up like, according to the program we are conducting, what are the main, what are the things we are looking for? Is their name, their contact numbers, and maybe their zip codes and where they stay, so that the CHW can actually connect them to a service in the zip code. So we kind of we try to see them very necessary information for them to engage with us, because when they start having more and more questions asking about their date of birth, their everything, there, most of them, especially those who are immigrant, they feel like, okay, this is very suspicious, and they hang up. They don't want to respond anymore. They just say, okay, we don't want to continue. So this is a very good question, and we need to answer this. When can we use the comprehensive assessment, and when we can tailor it according to the different programs?
Yeah, that's especially, Mike, I completely agree with everything you said. We find exactly the same things. We've also found it with our seniors and our older residents of Prince George's County. And since this is healthcare focused, that's going to be a significant portion of the population we're talking about. Asking somebody if they have a copy of their birth certificate when they were born 90 years ago is maybe not necessary to be able to connect them to a food pantry, right? So like there are some things that we found, even especially with our older homeless residents, that getting into the more in-depth questions just becomes more and more complicated.
Thank you both. And this is a great discussion. I think obviously we'll have to think about a lot of things as we start to build any kind of tool to do this outreach, but I appreciate it. And we'll do some more research into some of the models that you mentioned. I am always aware of our time. I know we've now kept people over, but I want to quickly just remind everyone, next month we do have CRISP coming. This will be a great opportunity for us to ask some questions of our health information exchange and get more information around how we can implement our next steps. So please try to join that meeting if you can. And of course, it'll be recorded if not. And just one quick announcement. This weekend, there's a men's health forum and resource event. It is taking place at in McCormick Drive from 9 to 12. There's a free registration, and it looks like there might be lunch. So go have some lunch and learn about health. And our next meeting again, Thursday, July 25th. Dr. Carter, any closing remarks?
No, I'm just so grateful that everybody's here, and we've got a lot of work to do, and I'm encouraged that we're getting ready to get there. So thank you guys for everything. Have a great weekend, and we'll see you in next month.
Thanks, everyone.
Thank you.
Thanks, everyone.
Bye-bye.
Bye-bye.
Yeah.